Hello everyone. Let's begin a major chapter, that is wounds. This is a very important topic. It could be a short note in the final professional exams, or it even for your practical life in the future. It's a very important topic because patient coming with wounds to your clinic or OPD is a very common scenario, right? The first thing that we need to do is to define wound, correct? Every one of us would have suffered wound in our childhood, right? Even some of us might have gone through fractured bones also. Everything is a wound, but then in exam we need to define it. We need to put it into a particular set of words, right? So what it is, wound, it can be defined as break in the integrity or continuity of the skin or any tissue. It could be anything. It could be as small as an abrasion, or it could be as big as some solid organ injury, liver injury or splenic injury, or it could be even bone fractures, right? Now, what is the difference between ulcer then? Between wound and ulcer. So ulcer is a specific word which we use only when there is breach in the continuity of the epithelium. Okay, we don't call bone fracture an ulcer, right? That exactly is what the difference between wound and ulcer. Okay, the second important thing is to classify the wounds. Okay, there are different ways of classifying wounds. One of the ways and easiest way is to classify it as tidy wound and untidy wound, and such a classification is called Rank and Wakefield classification. Remember this name, guys. Okay, now tidy and untidy wound, the name itself tells us how could the wound be, right? Any surgical incisions, planned surgical incisions, is a tidy wound. Any wound that happens because of the sharp object, maybe glass injury or some knife injury, okay, clean cut injuries, these are all the examples for tidy wounds. Why is it called tidy wound? Just by looking at the wound, you know, because there is no contamination, there is no pus here, there is minimal loss of the tissues. Even though there is loss of tissue, the cut edges look very healthy, right? The edges are not ragged like you see here in this image, which is an untidy wound, right? The untidy wound, because of the mechanism of injury, they are by the way it has happened, it can be a crushed wound or an avulsed wound. There's lot of contamination when the tissue get crushed or avulsed, right? And lot of, it's not just the superficial epithelium, that superficial skin that gets abraded. There are a lot of tissues that get devitalized and unhealthy, and there is lot of tissue loss also. Okay, the untidy wounds could be crush injuries, tearing injuries, avulsion injuries. Okay, and it's not just that, there can be associated underlying vascular injuries also, fracture of the bones also. Even burns are categorized under untidy wounds. We saw here in the previous image, the wound edges are so ragged, they are not as neat as this tidy wound looks, correct? So you can't directly go and suture such an untidy, unhealthy wound, because if you suture, definitely it will go for wound dehiscence because of infection, and always there is delayed wound healing in such a untidy wound. Then how will you manage such an untidy wound? Always go for liberal excision of the devitalized tissue. All this unhealthy tissue must be excised. You can't leave it behind. It will not let the wound heal. Followed by healing by secondary intention. What does this mean? You first excise the devitalized tissue, do daily dressings of the wound, keep the wound clean, and allow healthy granulation tissue to be formed. Okay, only once the granulation tissue is formed, you can go about with secondary suturing. Or if the wound size of the wound is too large, wherein you can't approximate the edges, then you can go for split thickness graft or flap. Okay, The next way of classification of the wound is based on the thickness of the wound. It could be superficial wound, partial thickness wound, or a full thickness wound. We all have studied how the layers of the skin, right? So the topmost layer would be the epidermis, then we have this papillary dermis, and then we have this reticular papillary dermis, and this is the reticular dermis or the deep dermis, wherein all the skin appendages like the hair follicles or the sweat glands or the sebaceous glands, right? Now what superficial wound, if only the epidermis is peeled off like an abrasion, then it would be called a superficial wound. If epidermis along with the deep dermis is involved, but then there's no much damage to the skin appendages, then it would be a partial thickness wound. Full thickness wound is when the entire skin including the epidermis, dermis is peeled off along with the subcutaneous fat. Okay, that is a full thickness wound. The next way of classification is again simple wound and combined wound. The name itself tells you, simple wound, only one organ is involved or only one tissue is involved, like just skin is peeled off or just one organ is injured, correct? Now combined wounds, when there are multiple injuries to different tissues of the body, skin is also peeled off, there may be associated bone fractures, there could be associated muscle necrosis, okay, there could be associated vascular injury, nerve injuries, etc. This is called combined wound. Coming to the classification of the surgical wounds, this is one, the surgical wounds as in the incisions that we give or the way basically the incision, surgical incisions that we give, they are called surgical wounds. Okay, how do you classify such wounds? It's very important for our day-to-day clinical practice also, right? Clean surgery, clean contaminated surgery, and dirty surgery. Clean surgery is when no hollow viscus is opened, like you are not touching the gastrointestinal tract or urinary, the gastrourinary tract, or any such of such hollow viscus is not touched. So there is no contamination by feces or there is no contamination by urine or anything. A simple example would be a hernia surgery, right? It's a anterior abdominal wall surgery. You don't enter any intestines or gallbladder or appendix, so there is no much of contamination. What is the importance of knowing this is that to understand, like what is the importance of knowing if what surgery is what sort of surgery. This is because we need to know the infection rate with prophylaxis and without prophylaxis. That means if you give antibiotics, prophylactic antibiotics before surgery, and if you do not give the antibiotics before surgery, what is the infection rate that you can anticipate, which is 1% in case of clean surgery with antibiotics or without antibiotics, which means there is no role of giving prophylactic antibiotics in clean surgery. Even if you give antibiotics, the chances of the wound getting infected is 1%. Even if you don't give the antibiotics, the chances of the wound getting infected remains the same, right? Now, the second way of classification is the clean contaminated surgery. Okay, what is clean contaminated surgery? Initially, to begin with, the hollow viscus are not entered, but eventually like when you keep operating, maybe by mistake you have perforated a hollow viscus. For example, you are performing a laparoscopic cholecystectomy and you have cut the gallbladder, you have excised the gallbladder from the gallbladder fossa, but while extracting the specimen, you have caused spillage of the sterile bile into the peritoneal cavity. This is a very easy and day-to-day example of clean contaminated surgery. Okay, viscus is opened okay, the GIT or genitourinary tract, whichever you are operating on, that viscus gets opened, but the spillage is minimal, and it's not the whatever is getting spilled, it's not contaminated as much as in a dirty surgery. Okay, what is the difference between clean, contaminated and dirty surgery? In dirty surgery, whatever is getting spilled, that is very contaminated substance like pus. Okay, spillage of pus from gallbladder. The same example I gave you here, the laparoscopic cholecystectomy. If you are performing that laparoscopic cholecystectomy on a patient with acute cholecystitis with some PIOC, and then you happen to perforate that gallbladder, and then what spills is the pus in the peritoneal cavity, then it becomes a very dirty surgery. Okay, it is the worst wound possible. Okay, then the contaminated surgery. So then what is just the contaminated surgery? Contaminated surgery is when you are performing surgery on an appendiceal abscess. Already abscess is formed and then you are operating on it. Here the abscess is not formed. Okay, there is no abscess here. It's the normal organs here. Okay, here now the abscess has been formed. Here the patient has already come with the perforated abscess. Here the okay, I'll tell you again. See, it's very simple and easy. Do not get confused. Clean, contaminated, there is no pus at all. There is no question of pus here. Okay, in contaminated surgery and dirty surgery, okay, there is pus. Here in contaminated surgery, it has not yet spilled. Here the patient comes with the already pus in the peritoneal cavity, like duodenal ulcer that has perforated. He has come with peritoneal cavity filled with feces, or the gastric ulcer that has perforated. He has come with the peritoneal cavity filled with the gastric contents, right? All these come under dirty surgery. Okay, contaminated surgery is when patient comes with the appendiceal abscess or some perirectal abscess, diverticulitis that has formed an abscess, but yet there is no spillage. Okay, now clean contaminated surgery is when there is no question of pus here. Okay, there is no question of pus here, but then if at all you cause perforation, for example, if you perforate a gallbladder, the sterile bile leaks. Okay, because it is a planned surgery, even if you perforate a bowel, there would be spillage, but very minimal spillage of the bowel contents or the intestinal contents. Again, the importance of knowing what type of wound is what lies in this one, like what is the infection rate that you can anticipate with prophylaxis or without prophylaxis. Definitely in a dirty surgery, if you do not give antibiotics, the chances of wound getting infected is 40%. Okay, with antibiotic prophylaxis, the chance comes down to 7%, right? In contaminated surgery, with prophylaxis it is 6%, without prophylaxis it is 10 to 20%. In clean contaminated surgery it is 3%, and without prophylaxis it is 5 to 10%, 1% each in case of clean surgery. Okay, have you understood so much clearly? If there are any doubts, please ask the doubts in the comment section. I shall reply to it. Let's move to the next heading, that is wound healing. We have now understood what is wound, what are the different types of wound. Now let's move on to wound healing. Okay, now what is wound healing? Again, you have to define wound healing, though everybody knows in the common language what a healed wound means, right? Because we all have suffered injuries, we all have seen the wounds healing in a week or in a month's time, right? But if you have to put it into words, it's a complex process of the body to regain anatomical and the functional integrity of the disrupted tissue, right? Whenever there is wound, it means that part's anatomy is disrupted and that part's function is also disrupted, right? Suppose you have a broken bone, can you function normally with such a arm or such a limb? No, right? There is the functional integrity is lost, right? Okay, now wound healing is a complex process to regain such lost functions again into normalcy. Now, what are the different types of wound healing? There is healing by primary intention, healing by secondary intention, and healing by tertiary intention. Okay, before going to the stages of wound healing, let's understand each of these. It's very important even for your entrance exams, NEET PG entrance exams. They give you an example and ask if it is primary healing by primary intention, or healing by secondary intention, or healing by tertiary intention, third intention, which is also called the delayed primary closure. Okay, it's very simple. Just understand what it means, and then there is no question of doubt in these topics or the questions that gets asked. Okay, now what is healing by primary intention? It means that whenever you do a primary closure of the wound, primary closure we already discussed in our previous slides. If the wound is very clean and healthy, and it's the edges are very close to each other, but still it takes lot, if you leave it alone, it would take a lot of time to heal on its own. So then you go about with primary suturing the wound, correct? So when you suture such a clean and tidy wound, this is called healing by primary intention. Okay, so healing by primary intention, wound edges, here the wound edges are opposed to one another, that's why you suture it. It will result in faster healing and minimal scar. That's the advantage of suturing a wound: faster healing and minimal scar. Okay, now what is secondary intention? Suppose, consider you have a wound of size maybe 4 into 6 centimeter. Okay, now but it has got slough in it, it has got serious discharge coming from it, it has got pus in it. Okay, then what do? In case of an infected or a sloughy wound, you can't suture it straight away. I told you earlier, if you suture such an infected or wound filled with slough, that will give away, it will not stay, it will result in wound dehiscence. Okay, so in such cases you leave the wound open, you clean the wounds, or you do daily dressings of such wounds, you basically with betadine or normal saline, and promote healthy granulation tissue. Okay, healthy granulation tissue. And this also promotes reepithelialization and contraction of the wound, and basically healing by secondary intention means allowing healthy granulation tissue to develop. Okay, next, what is healing by tertiary intention or delayed primary closure? This means that initially the wound was unhealthy, that's why you let it heal by secondary intention, and then you are allowing the granulation tissue to develop. Now the granulation tissue has developed, and then the wound looks very nice, red and healthy. Okay, now what do? Now if you just leave it open and allow it to heal on its own, it will heal with a very bad scar, and it will take very long time to approximate. Okay, because it's a very large wound. So what do? You take up the patient. If the edges can be approximated, then you do a secondary suturing. If the edges can't be approximated, then you do a flap closure or a split thickness graft closure. And such a wound healing is called as delayed primary closure, because you are suturing the wound or you are closing the wound, but it's slightly delayed because you are giving some time for the granulation tissue to develop, right? Okay. Next, coming to the stages of wound healing. This is a very important question that is asked. Okay, what are the phases of wound healing? As soon as one person suffers injury, okay, what happens? First is the hemostasis. How does the body react whenever we attain any sort of wound? First step is hemostasis. That is, the blood vessel, whenever we have an open wound, the blood vessels that have been exposed there, first step is they undergo contraction so as to achieve hemostasis. Okay, then actually you can also like the stages of wound healing, it can also be, you can combine the first two stages and call it as stage of inflammation plus hemostasis, and then take it as just 3 stages of wound healing, or you can separate these two things and then call it as 4 stages of wound healing also. Okay, both are correct ways. Okay, now once there is, first step is control of bleeding because of vasoconstriction and thrombus formation to stop the bleeding. Once that happens, what happens next is, eventually there is, after the initial vasoconstriction, there is vasodilation. Okay, why this vasodilatation has to happen? This is because to allow the release of all the inflammatory cytokines and these macrophages and polymorphonuclear cells, the macrophages, so that they can come to the site of wound and clear off all the debris and the infection, right? This is the first step that happens whenever a person sustains injury. What is the next step? Okay, the first step, it occurs up to, by 2 days. Okay, the stage of proliferation happens from 3rd day till 3 weeks. The stage of remodeling is after 3 weeks, starts after 3 weeks and goes on till almost up to 12th week. This is as per Bailey and Love. Okay, 12th week. Okay, now what is the stage of proliferation? Stage of proliferation basically means there is neovascularization. Can you see these small new blood vessels that have come up here? Okay, that is neovascularization. That is the neovascularization that happens to allow the proliferation of new cells. That is re-epithelialization also happens. Plus another thing that happens here is the immature collagen formation. Immature collagen formation, which is the type 3 collagen, Okay, so there is neovascularization, re-epithelialization and immature collagen formation, which is type 3 collagen. Okay, let's go to the final step, which is the phase of remodeling. Okay, phase of remodeling basically means that the immature collagen that was formed during the phase of proliferation now gets converted to the mature collagen. The immature collagen gets converted to the mature collagen. We said immature collagen is the type 3 collagen and the mature collagen is the type 1 collagen. Okay, and the type 3 is to type 1 collagen during the phase of remodeling is in the ratio 1:4. Okay, this is an important multiple choice question for you, right? Okay, now let's move on to the next topic, which is what are the factors affecting wound healing. We all have seen that some take just 1 week for the wound to heal, and in some patients it may take really very long for the wound to heal. Okay, why is it so? That is because there are a lot of factors which affect this healing process. Okay, it's not as simple as it looks. Okay, that is Now, okay, what are the local factors? What are the factors which are specific to the wounds that can delay the process of wound healing? One is desiccation. If the loss of tissue, suppose consider there is a 1 into 1 centimeter wound, and consider there is a 5 into 10 centimeter wound, a very very big wound. Logically speaking, this wound will take longer time as compared to this wound. Okay, depends upon the amount of desiccation, that desiccation of the tissues that have happened, amount of maceration, amount of necrosis, basically the size of the wound, amount of the tissue loss that has happened. All these things are the local factors which affect wound healing, correct? Also the infection and the bacterial load. If the wound is infected, then definitely it will delay the process of wound healing. Okay, if there is continuous pressure that is applied on the wound, whatever new tissue that is formed, whatever the epithelialization has happened, that gets peeled off. Okay, you have to give some time for the epithelium to the new epithelium that has formed to sustain. But if there is constant pressure, like in case of bed sores, okay, bed sores, they never heal, or they take a very long time to heal. Okay, that is because the whatever the new epithelium is formed, that gets swept away because of the constant pressure. If there is edema also delays wound healing. Even trauma, if it is the wound has been caused by some road traffic accident, okay, the patient has been swept on the main highways or the roads, definitely he would have been carrying lot of infection and germs from that area. So it will take a lot of time to healing as compared to the clean surgical incisions that we put in the operation theaters, which will heal very quickly because we maintain such aseptic precautions in the OT, correct? Okay, now what are the systemic factors which will affect wound healing? One is the age. Younger patients, the healing would be very fast as compared to the older age. Okay, now that is because the blood vessels would be atherosclerosed in elderly. The blood supply would be limited to the wounds to let it heal. Diabetes, everybody knows diabetes, the wound healing is very poor. Obesity also hampers wound healing. Okay, hypothyroidism, immunosuppression can predispose to lots of infections. Infection means delayed wound healing. Okay, corticosteroid use, this also is a condition of state of immunosuppressed state, right? Okay, that is the reason it also will delay wound healing. Radiation therapy, chemotherapy, again these are the immunosuppressed conditions, right? Now the laboratory values, macro and micronutrient deficiencies, iron deficiency, if the patient hemoglobin of the patient is low, if the patient is nutritionally deficient, then again the wound healing will be delayed. Vascular insufficiency, if the patient is suffering from Burgess disease, or if the patient is suffering from atherosclerosis, if the blood supply to the wounded arm or limb is not good enough, then the wound healing is delayed. Smoking also delays wound healing. Okay, now so how do you manage wound? Suppose you are an intern in surgical ward and you have patients in your ward who have different kinds of wound. How will you manage these wounds? Or suppose you are in a casualty and you come you see a patient who has come with some fresh wound in his limb. So then how do you manage such wounds? First thing is to inspect and decide what sort of wound the patient has sustained. Okay, not just that, you have to also examine for the underlying muscle, bone, vascular injury, which if at all is present, you will treat those things first before going on to cleaning the dressing the wound, right? Vascular injury, definitely it would be life threatening otherwise, or limb threatening otherwise. Bone fractures, if you don't heal the underlying bone, then Superficial wounds will never heal. Muscles also, if the muscle is necrosed and you do not debride such a muscle, the superficial wound will never heal, right? That's why it's important. You need to do, whenever the patient, if a patient has come with the big wound in his limb, then you will have to get the x-ray of the underlying bone also. If you are suspecting, you first palpate the wound and see. If you feel the bone crackling, or you feel that the patient is not moving his limb, then you may, if you are suspecting bone fracture, you will ask for the x-ray of the limb and then decide what to do next. Okay, if it's a clean incised wound, then you can take up the patient for primary suturing. But if it is a crushed wound, then it has to be debrided first, followed by delayed suturing or STG as needed. Okay, and if it is a crushed wound, avulsed wound with lot of infection, slough, etc., you have to start the patient on antibiotics. If patient is diabetic, the blood glucose control is very important, without which the wound will never heal. The electrolyte corrections are important. Vitamin deficiency, if any, has to be corrected. Blood transfusion, if the hemoglobin is too low, even then the wound healing gets delayed. And patients with fresh wound in the casualty always have to be given the tetanus toxoid injections. Okay, this is how you make the wound. This is how you debride the wound. Okay, this is a wound, it's not that healthy looking. See, can you see the yellowish slough here? This is the slough. There is also serous discharge here. Okay, if you leave it alone, the serous discharge might become pus also because of the growing infection. What do you do during debridement? You remove all the slough, this yellowish looking thing. You have to scrape it off and make it look red and healthy. Now, what is a healthy wound? The definition of healthy wound is it has to bleed on touch. As soon as you put a scalpel over this, or you put a gauze paste and you scrape it off, it has to bleed. There has to be pinpoint hemorrhage. It should be red and healthy looking. That is what you do during debridement.